Well, good afternoon, everybody. My name is James Church. I'm a colorectal surgeon here at the Cleveland Clinic. I've actually been here for 35 years. Um, and during that time, I've been chair or leader of the inherited colorectal cancer registries here in the Department of Colorectal Surgery. That dates back to about 1976 when it was started by David Jagelman, who was one of my tutors and then one of my partners, and then went down to um, Fort Lauderdale to head up the colorectal unit down there in 1988. So since 1989, I've been concerned with hereditary colorectal cancer, and then that naturally leads on to a concern for sporadic colorectal cancer. It's hard to separate the two. Hereditary colorectal cancer is just an amplified, exaggerated version of sporadic colorectal cancer. And so the same techniques, colonoscopy, colectomy, are used for both. The only thing is it takes an understanding of the genetics to understand inherited colorectal cancer, but that's a topic for a different day. So today we were going to talk initially about screening for sporadic colorectal cancer in general. There's been some developments there that it's useful to know about, and then focus for the rest of the time on an aspect of inherited colorectal cancer. So hopefully you find this instructional and interesting. And we'll start off with sporadic colorectal cancer. So I think it's important to realize just what a health problem this is. So American Cancer Society estimates about 147,000 cases newly diagnosed every year, and certainly this year. That's a lot of patients with colon and rectal cancer. And then about 50,000 will die of it, and that's a lot of deaths. But if you look at it on a daily basis, it translates to 405 new cases per day in this country, which is astounding, really. And then 146 people dying every day. We see the number of deaths from COVID, but this is up there with it, 146 people dying of colon and rectal cancer every day. So it's very frustrating, though, because this is a curable disease. Not only is it curable, but it's preventable. So none of these patients had to get colorectal cancer, and certainly none of them had to die from it. And the reason is that colorectal cancer always starts in a pre-existing benign lesion, mostly a polyp. But you don't just have normal colon mucosa and then all of a sudden you have cancer. There is a sequence of a small adenoma to a mid-sized adenoma to a large advanced adenoma and then to cancer, and it can take on the average about 10 years for that sequence to happen. So we have a 10-year window to get in there and take out that polyp and prevent cancer. But it's not happening. Colorectal cancer is also curable, and here are some data from our department here at the Cleveland Clinic over the years compared against a group from the SEER database, just for comparison, and you can see that stage 1 cancers are pretty much all curable. Stage 2 cancers at 90% are curable, and stage 3 cancers, those are those with lymph node involvement, about 70% curable. So not a very deadly cancer if you catch it in time. And catching it in time is the point, because that needs screening. So screening can be defined, as you can see here, testing of an asymptomatic people with the aim of making a pre-symptomatic diagnosis of early stage curable disease. For colorectal cancer, we would add preventing the disease by removing precancerous lesions. So when we're talking about colorectal cancer, the first thing to do is to sort out your risk status. Now, average risk means none of these things. So no personal history of colorectal cancer or polyps, no family history, no IBD, no hereditary syndrome, and no radiation in the past. So that's what we call Mr. and Mrs. average risk, and most of the guidelines are for average risk people. And these are the options for the screening, and they can be broadly divided into stool-based tests, or what I would call cancer detection tests, and visual exams, which is more like preventative tests. So you can't take off a polyp with a hemocult, basically. You may be able to detect a cancer, but you can't take off a polyp. Colonoscopy is the gold standard. This is the way of diagnosing and removing precancerous polyps or diagnosing early stage cancer if you do it in asymptomatic people. That's the point, asymptomatic people. These are the American Cancer Society guidelines, so we're supposed to start regular screening at age 45. It always used to be 50, but because of an increase in the incidence of cancer in young people, the starting age of screening has been brought down to 45. And then this just goes through the different age recommendations. So as you advance in age, there are slight changes. So regular colorectal cancer screening, which is every 10 years, if you don't find anything, goes up to age 75. And from 76 to 85, then it's based on life expectancy and morbidity. Over 85, people get a break, no more screening. I guess they figure that you're not going to live anyway, so who cares? I go by life expectancy right up until the patient only has 5 years or less to live, and then they can stop screening. So these are the kind of new aspects of screening I wanted to talk about. The first is fecal DNA testing. Then there's blood-based screening, serrated polyps, colonoscopy quality, and the colon capsule. Of these, the most important one, I think, is fecal DNA testing. And this is a way of taking DNA out of the stool and looking at it for changes or aspects of the DNA that would suggest it came from a cancer or an advanced adenoma. And this idea has been around for 30 years, but the technology has finally caught up with the idea. And in 2015, there was a seminal paper published in New England Journal on 10,000 patients that underwent fecal DNA screening compared to FIT, or fecal immunochemical testing. And the Cologuard is the name of the fecal DNA test, and you might have seen it on TV as that little box with arms that's running around people's houses. That has a 92% sensitivity for cancer. So over 100 cancers, it will find 92. Colonoscopy has a 95% sensitivity, so pretty much the same as colonoscopy. FIT testing has a 71% sensitivity, so significantly less. The other advantage of the fecal DNA testing is it has a 72% sensitivity for advanced adenomas, and these are the sort of adenomas we want to find and remove. And it has a 42% sensitivity for serrated polyps, which are these hyperplastic and sessile serrated polyps, a different pathway to cancer. The polyps are hard to recognize, they're quite subtle sometimes, and they account for about 18% of all colorectal cancers. So the fecal DNA test will even find a decent chunk of these. And so if you can't afford or don't want to have a colonoscopy or can't get a colonoscopy, fecal DNA testing is a second best. If it comes back positive, then of course you do need a colonoscopy. But if it's negative, you can be pretty happy that all is well in your colon. And the recommendation is to do that every 3 years. There is a blood-based screening test called epiprocolon, which looks at methylated septin 9 in the blood. That sensitivity for cancer is only about 62-63%. So to me, I'm surprised that the FDA allowed that to go commercial, because it's only a little better than tossing a coin. Do I have colon cancer, yes or no? 50% chance. Well, 62% sensitivity is not great. So you're going to miss about 40% of cancers if you go with the blood test. I think with all of these genetic tests, technology is progressing so rapidly that in 5 years' time, they'll be much more accurate. And in about 10 years' time, I tell my patients that screening colonoscopy is going to be defunct. We won't be doing it. We'll be doing a blood test or a stool test and then only scoping the positive ones. So all these negative colonoscopies that we do now that in retrospect are a waste of time, we won't be doing. So there's Cologuard epiprocolon. These are serrated polyps, and you can see instantly they don't look like adenomas. Adenomas look like a little raspberry in the colon, or a strawberry if you like. These are covered with mucus often. They're pale, they're flat, they're a little gelatinous. Here you can see some bile is on them. Easy to miss, very easy to miss. And this is the reason why there have been some studies showing that colonoscopy doesn't protect people against right-sided colon cancer. This is the reason, because these serrated sessile serrated polyps are on the right side of the colon. They're due to hypermethylation related to a BRAF mutation, and the hypermethylation knocks out tumor suppressor genes and encourages dysplasia in these polyps and then cancer. So this is me on my mission to rid every colon in Cleveland of precancerous polyps. This is a study that looks at colonoscopy and shows that it doesn't protect against right-sided colon polyps. So you can see this first line here, attempted colonoscopy. If there are no colonoscopy is done at all, the odds ratio of having cancer is 1. If any colonoscopy is done, for all colorectal cancer, the odds ratio is 0.69, so that's less than 1, so about 30% less. For right-sided colon cancers, it's a little bit greater than 1, so the colonoscopy doesn't protect at all. For left-sided, it's 0.39, which means that there is 60% protection. These data come from Ontario as a province in Canada, which makes you wonder what they're doing with their colonoscopies, to be frank. You know, if you're not preventing any cancers on the right side of the colon by doing colonoscopy, something's wrong, you know, and it's not biology so much as I think quality of colonoscopy. So colonoscopy has to be high quality. This is a picture of the colon pill cam. It's only slightly smaller than this, so it's a bit difficult for these poor patients to get it down. This is not caught on at all because it will see polyps, but then you have no idea where they are, and then you need a colonoscopy anyway and another bowel prep. So much better just to get the colonoscopy and then you can take the polyps off rather than to do this. But this is to me, I'm a bit cynical. This is an example of technology driving practice, or trying to. Unfortunately, it didn't take on. So why doesn't everybody in the country get a colonoscopy, you might ask? Well, there are lots of reasons. It's costly. People are scared of it. People hear bad stories about it. It just doesn't catch on with some people. That's the last thing they want to think about. They're scared of what could be found. They're scared of the test. Physicians have confused recommendations about it. It's not high on their priority list. It's hard for me to understand why they wouldn't recommend it, but they don't. And then health systems and insurance companies don't want to pay for it. And that may be the most common reason at all. I come from New Zealand. In New Zealand, the country cannot pay for screening colonoscopies, so they screen with FIT test, and if the FIT's positive, you can queue up for a colonoscopy that may take 6 months to a year until you get to the top of the list. Finally, just to transition into hereditary colon cancer, this is the results of a meta-analysis that look at the risk associated with a family history of colorectal cancer. So if there isn't a family history at all, your risk is average population risk, which is somewhere between 3 and 5%. So in an audience of 100 people, 3 to 5 of you are going to get colon cancer on the average. If you have one first-degree relative, a mum or dad, a brother or sister, or very unusually a child with colon cancer, your risk immediately goes up 2.5 times. So now instead of 5%, for example, it's 12.5% lifetime risk of colon cancer. If you have one first-degree relative who's under the age of 45 when they're diagnosed, the risk rockets up to 5-fold. So now you're up to 25% lifetime risk. And this is where we're thinking maybe there's a hereditary syndrome. If there are 2 first-degree relatives, the risk is 8 times higher. So up to 40% lifetime risk of colorectal cancer. If you have FAP and you carry the gene, the risk basically is 100%. So that's the apex of the familial risk. But these different nuances of family history are important. And any family history, any first-degree relative, should mean that you go to colonoscopy 10 years younger than your affected relative, or at age 50, whichever is the youngest. I just want to finish the screening with some perspectives. So these are broad comments that we've been making, but I always make the point that if a patient is sitting in your office and says, "Doctor, I don't want to get colon cancer, what should I do?" and you say get a colonoscopy by somebody who's good. That's clear. But what about the Minister of Health or the Secretary of Health that says, I don't want anyone in the country to get colon cancer? You can't say everyone should get a colonoscopy, we just can't afford it, it can't be done, there aren't enough colonoscopists. So the realities of screening a population are different to the realities of screening one person. The concept of risk is very important, we've said that. We've talked a little bit about who's going to pay and the likely compliance. Let's move on now to hereditary colorectal cancer. And I wanted to start off by talking about the aims of treatment. So the aims of treatment are not to get another pouch on your belt, like a notch on your gun. The aims are to prevent death from colorectal cancer, that's number one. Now we can't always prevent the cancers, but we hope to prevent death from cancer. And then at the same time, and almost as important, to minimize the impact of treatment on lifestyle. So it's all very well to take a 12-year-old boy with FAP and give him a pouch and an ileostomy, and you think, oh, he's not going to get colon cancer, but he's going to go to school with his ileostomy, people are going to laugh at him, he's going to get miserable, depressed. You close his ileostomy, he gets a fistula, you give him his ileostomy back for the rest of his life. You've ruined that life. You might have prevented colon cancer, but you've ruined a life. And so a balance of these two aims is extremely important. The challenges of treating hereditary colon cancer syndromes are that, number one, they're an accelerated multifocal carcinogenesis. So the cells are revved up to produce cancers, and every cell in that patient's body is affected by a germline mutation. So that means surveying multiple organs, and it means surveilling them more commonly than you would outside of these sort of syndromes. So every patient is a little different. The severity of the neoplastic sort of drive varies with the site of the gene, with the gene itself involved, and then by other factors like gender. For example, women in FAP get desmoids twice as often as men, and thyroid cancer 3 times as often as men. So there are various modifying factors. But for each patient and each family, the aggression of the syndrome governs the frequency of the surveillance and what you do about it. They all, however, start young, and FAP is one of the youngest. It usually starts in puberty. So you're taking these young kids and you're scoping them and operating on them, and often they have no symptoms. They're wondering, what the hell is going on? Why am I having this? And then they see their father or mother with their version of the disease. And it's very stressful. And it's important that things go well. And I mentioned now that patients are often asymptomatic. So it's one thing to take someone with ulcerative colitis who's pooping their pants 100 times a day and can't make it to the toilet and give them a pouch and they're happy. You take someone who's got normal bowel habit and give them a pouch, and now they're not normal, and now they're unhappy. So it's all a perspective from the patient's point of view. Sure, you've saved them from having cancer, but you've turned their life into toilet-dependent living, which is not what they had before, and they're not going to be happy about that. So this is a list of the most common hereditary colorectal cancer syndromes with the lifetime risk of colorectal cancer. And you can see it goes from 100% for profuse FAP down through mild FAP, attenuated FAP, MYH-associated polyposis at 50%, that's recessively inherited. Polymerase proofreading-associated polyposis, so uncommon it's hard to really catch a risk, but probably about 70 or 80% of cancer if it's untreated. Sessile-serrated polyposis, about 35%. Juvenile polyposis, Peutz-Jeghers, Cowden's disease, mixed polyposis, and Lynch syndrome. So the most common of these syndromes is Lynch syndrome, and the one we know most about and the second most common is FAP. So these are the options for treating the large bowel in patients with hereditary colorectal cancer syndrome. So remember, our aim is to prevent death from cancer, or there are 2 ways of doing that. Again, these syndromes follow the rule. There's always a precancerous lesion before the cancer in the colon. And so you can do endoscopy to take out the precancerous lesions. The advantage is minimal morbidity, but the disadvantage is frequent exams and the possibility of missing cancer and getting an interval cancer, or surgery. And surgery markedly reduces the risk of cancer. That's the advantage. The disadvantage is it's surgery. So changes in lifestyle, changes in bowel function, and potential for complications. So again, it's your choice is governed by what's ahead of you. And in patients with what we would call attenuated or oligopolyposis, less than 100 adenomas, I'm quite happy to do a colonoscopy and take them all out, rather than take their colon out. And a patient with 1,000 polyps, there's no way I can take those out, so they're going to get a colectomy. If their rectum is relatively spared, we will leave the rectum and do an ileorectal. If their rectum is full of polyps, we'll take the rectum out and do a pouch. So these are the obvious choices. If someone has a cancer, then you have to do surgery. You can see profuse polyposis, surgery. Attenuated or oligopolyposis, colonoscopy. So for FAP, colorectal cancer screening begins in puberty. So around about 10 or 11. That's when we do the genetic testing to see if they're affected, and that's when we would start checking them. We prefer not to operate until the late teens at the earliest, because that's a time when they're at least relatively mature as teenagers ever get. They're usually at the end of high school, so they're transitioning to college. And surgery done laparoscopically or minimally invasively is not such a big deal for these kids as it used to be. So doing a colectomy and IRA, very few small incisions. They're usually out and about running around in a couple of weeks. These are the indications for colectomy and FAP. So cancer, profuse polyposis, polyps you can't remove, symptoms, and an inability to check the colon with colonoscopy. Maybe it's too twisty. Relative indications for surgery. So if we're not operating, we're following along with the yearly colonoscopies. And if one year you have 100 polyps and the next year you have 500, that's an indication to think strongly about surgery. If you take out a polyp with high-grade dysplasia, that's also an indication for surgery, because if you have it in one polyp, you may have it in others that you didn't take out, and high-grade dysplasia is just one step away from cancer. And then lots of large polyps is also a relative indication. So when we think about surgery and FAP, we're thinking about the timing of the surgery, from social point of view, academic, financial, and disease-related point of view, and the type of surgery and the surgical approach. So if there's a cancer or symptoms, then obviously you're going to operate right now. If it's mild polyposis, they're asymptomatic, then you can put it off into an appropriate time in the family setting. If there's a high risk of desmoid disease, we tend not to operate until our arms are twisted way up behind our backs, because most desmoids in FAP occur after a surgery. Surgery is the initiating event that stimulates desmoid formation in a third of patients with FAP. But you can triage patients according to their risk of desmoids, and the high-risk ones we don't want to operate on ever if we can avoid it. The good thing is that a high desmoid risk is associated with a low polyp count, so quite often you can put things off. Desmoids are much more common after a pouch than after an IRA, and so if you have to operate, it's better not to make a pouch, and usually that's possible. This is a histogram that shows the age of surgery in FAP in our department, and you can see the mode is around about age 17, and there's a long tail in the attenuated polyposis cases. So the choices between a colectomy and IRA and a proctocolectomy and pouch. And these are the pros and cons. So the pros of an IRA are it's quick, safe, uncomplicated, good quality of life, good bowel function, controls the polyposis in the colon, no stoma, and easy surveillance. The con is the risk of rectal cancer. The pouch is good for patients with a high risk of rectal cancer, but you can see the disadvantages in the pouch. High complication rate, bowel function is unpredictable, generally need a temporary ileostomy. You can still get polyps in the pouch, you get polyps and cancer in the anal transition zone. Quality of life is unpredictable. Surveillance can be difficult. So there's no real easy answer, but if I was going to have an operation for FAP, I would be having an IRA. Thanks very much. So this is our practice in the department, and you can see in the rectal polyp counts, when there's less than 5, we're pretty much doing an IRA in everybody. When there's more than 20, we're doing a pouch, and most people, a few, are getting the IRA. Laparoscopic is the way to go these days. These are young patients, relatively asymptomatic, and laparoscopic surgery is very good for them. Recently in FAP, we've adopted a more conservative approach to surgery because we keep seeing patients referred in with surgical disasters. And so for all the reasons that we've talked about, we've kind of to back off away from the more aggressive surgical approach. So we tend to want to delay surgery a little bit longer, especially in patients with attenuated polyposis and the desmoid risk. We want to do IRAs, and we do IRAs more often these days. We accept more polyps in the rectum. We clear those out endoscopically. And one of the reasons in young girls is that a pouch will impair their ability to conceive and reduce it by about 50% in patients with FAP. So for young girls that want to have a family, we try and keep their rectums. And then if we have to do a pouch, we do it open, because we found that laparoscopic pouches are much more likely to form desmoids than open pouches. And we've become more aggressive endoscopically and try to control the polyps endoscopically. There is a potential option for chemoprevention. There have been multiple studies of drugs in FAP to try and control the polyps. None work absolutely, but there is a combination of DFMO, deoxyfluoromethyl ornithine, and Sulindac, which looks really promising. But this is brand new, and we're just in the process of trying to publish that, but that could be a bit of a game changer in FAP. I just wanted to show you this quote. We've done a survey of FAP patients looking at their mental health, and in that we asked them, what has been the most helpful thing in your FAP journey? And one young boy answered in this way. He said, my mother telling me that they didn't take and give me the bag. The doctor experimented by leaving the 6 inches to the anus. This gave me a chance to get through high school without being picked on and not looking like a freak. So that tells you really what sort of a difference that your surgical approach makes to these patients. The last couple of minutes now, let's talk about Lynch syndrome. This is me and Henry Lynch, the oncologist from Creighton University in Omaha, Nebraska, that Lynch syndrome was named after. Unfortunately, Henry died about 3 or 4 months ago at the age of 93, so he had a pretty good innings, but he remains a legend in the field. So Lynch syndrome is inherited DNA mismatch repair instability. It arises because of a germline mutation in a mismatch repair gene, and these are the 4 mismatch repair genes: MLH1, MSH2, MSH6, and PMS2, and the cancer incidence in patients that carry what we now call a pathologic variant in these genes in their germline. It's the most common form of hereditary colon cancer. About 3% of all cancers come from Lynch syndrome, and 1 in 279 people in the population carries Lynch syndrome in their genome on the average. So it's quite common, really. We just tend to miss it because we don't look for it. We don't take family histories like we should. We don't think about it when we take polyps out. We miss it. But these people are out there and we have to diagnose them. So let's say we diagnose someone with Lynch syndrome. What are we going to do about their colon risk? So when we're talking about surgery, there are 3 different types of surgery. This is the way I like to look at it. So there's primary prophylaxis, secondary prophylaxis, and tertiary prophylaxis. Primary prophylaxis is you have somebody with Lynch syndrome in their germline, but no cancers and no polyps. What about just taking their colon out? And then they're not going to get colon cancer. but their colon looks normal. It's not normal because in each colonocyte there's a mutation, and they're at high risk of getting a cancer, but they don't have a cancer. So that's primary prophylaxis, is just to take someone with Lynch syndrome and take their colon out. The secondary prophylaxis is somebody with Lynch syndrome gets a cancer, but instead of doing a segmental colectomy, you take their entire colon out to prevent them getting another cancer. And so that's secondary prophylaxis. Tertiary prophylaxis is somebody that's had a cancer and had a segmental resection, and then so they come to see you and they've already had a right colectomy. And you say, well, we should go in and take out the rest of your colon, even though it's normal. So that's tertiary prophylaxis. And these are all decisions that need to be gone through with the patient, and because they have pros and cons. So the unaffected mutation carrier, should they have yearly colonoscopy or have their colon taken out? That's their choice. You have a mutation carrier with a cancer, should they have an extended colectomy, a total colectomy and IRA, or a segmental colectomy with yearly colonoscopy of the rest of the colon? Or an unsuspected mutation carrier with cancer, so somebody's got a colon cancer, you don't think that they've got Lynch, but then the pathology shows you they've got Lynch. Should you go back and take the rest of their colon out, or should they get yearly colonoscopy? So it's a choice between surgery and colonoscopy. So primary prophylaxis, there have been modeling studies done which show that if you take their colon out when they're 25, the survival benefit is only about 1.8 years compared to doing surveillance colonoscopies for the rest of their lives. So not very attractive. But some of these patients have a very difficult colonoscopy. And to be facing, let's say you're 25 and you want to live till 75, 50 colonoscopies stretching out over the next 50 years, and each one is agonizingly painful and you have to take the prep, you could sympathize with those patients that say, well, I'll just take my colon out. Patients that have poor compliance, so you're going to send them an appointment for colonoscopy and they're going to say, no, I'm not coming, or I'm too busy, and then by the time they come and see you, they've got a cancer. So those patients should think about getting their colon out. Or some people have a psychological fear of cancer. They can't sleep at night in case they're just envisaging these colon cells turning into cancer right then and there, and that's all they can think of. So they should probably have their colon taken out. Or if there's a family with very high penetrance, so the mum got colon cancer at age 22, her sister got colon cancer at 19, their parents got colon cancer at 21, and you're 18, what are you going to do? It's looking like you're going to get cancer, so better to take the colon out under those circumstances. So there are circumstances where primary prophylaxis is good, not very commonly. Secondary prevention. So there have been lots of studies done on patients with Lynch syndrome having a segmental colectomy, and the risk of a metachronous cancer is around about 35% or so. So we have data on this. Yes, here are some data from us. So colon cancer getting a segmental colectomy, 37% got either a high-risk adenoma or another cancer after 6 years of follow-up. For rectal cancer in Lynch, there were 33 patients, and just over half got either a high-risk adenoma or a cancer after 6 years of follow-up. So our basic position these days in patients with Lynch syndrome is to do a total colectomy and ileorectal anastomosis if it's the colon. If it's the rectum, we still tend to just do an anterior resection, maybe a little extended, because we don't want to do a pouch. That would be if we were consistent in our philosophy in doing a total colectomy and IRA for the colon, we would probably want to do a pouch for the rectum, but we don't. It's just too much potential morbidity. These patients are older than patients with FAP. It's a slightly different equation. But here's a patient of mine with a 5mm polyp in the transverse colon, turned out to be a cancer. And you can see it's just in the middle of the transverse colon, a tiny little mark from where that cancer was. But you can also see by the nature of the surgical specimen that She lost her colon because of that tiny little 5 mm cancer. So that's complete secondary prophylaxis. And now tertiary prophylaxis. So you have a patient that had a colectomy for a cancer, then you find out on tumor screening that it's MSI high, and immunohistochemistry shows loss of MSH2. So Lynch syndrome. You do a germline analysis, they have Lynch syndrome. So now you're seeing them in the office, and you can say, well, we have two alternatives. You can have a colonoscopy every year, so you don't get another cancer, or we can take your cancer out. So the advantages of not doing the surgery are preserving function and not going through the risks of surgery. The advantage of taking the colon out is a much lower risk of having another cancer, and you don't have to have a colonoscopy every year. So in general, the risks of another surgery are higher than if it was the first surgery. And here are some data to show you that if you are doing a reoperation and there are adhesions, there's a significantly higher risk of an enterotomy, a significantly higher risk of serosal tears, and a significantly higher risk of major complications. So a reoperation is a more serious thing than the first operation. And to do a reoperation just for a theoretical cancer risk, probably not warranted in most cases, and we tend not to do that. So, in summary, primary prophylaxis for Lynch, done in high penetrance cases, young age of onset, cancer phobia, and difficult colonoscopies. Secondary prophylaxis, it's important to make the diagnosis of Lynch before you take the cancer out, not after, and then you can plan the appropriate operation, and we generally do an extended resection. Tertiary prophylaxis generally avoided. That means that the colonoscopy has to be very good. Final slide is to just remind everybody listening to this that hereditary colon cancer cases are complex. Patients are young and at high risk of cancer. The surgeries are demanding, the decision making is complicated, and colonoscopy has to be done by the very best to minimize getting unwelcome cancers. So if you have cases like this, come and see us at the Weiss Center and the Department of Colorectal Surgery. We're always willing to help and to talk about cases. We don't want to take them over necessarily, but always willing to give advice. That's what we're here for. Thanks for listening.